President, organizing Congress members, presenters, scientists, delegates, and exhibitors who participated in this great webinar events. Indeed, my subject will today with you is very important. Name Sgarbossa criteria in left band branch block in hypertensive emergency, a case report. Learning objectives, starting point, abstract, vocabulary or keys for the current case report, discovery, history, identification of keys, the case, case report, presentation, treatment, discussion, finally, conclusion and recommendations. The starting point or introductions. The researcher will be lucky if the case report will be including complex data. Sometimes case report take multiple directions. Understanding the physician should be a strong observer for the new clinical findings. Abstract is a summary for this current case report. Let us to understand this vocabulary or keys for the current case report. Left bundle branch block, Sgarbossa criteria and its modifications, hypertensive emergency, SCT segment elevation, myocardial infarction, the decision of thrombolytics in the left bundle branch block. Discovery history. Heavy smoker, Egyptian male, acute angina, chest pain, hypertensive crisis, ECG show, left bundle branch block with new progressive SCT segment elevation. Identification of keys for the case. Firstly, left bundle branch block and the SCT segment elevation myocardial infarction. Diagnosis of SCT segment elevation myocardial infarction or STEMI in the setting of left bundle branch block is still difficult. Timely and accurate identification of acute myocardial infarction or acute occlusion, coronary occlusions in the setting of ischemic symptoms is critical in initiation, urgent angiography, and appropriate reperfusion therapy. A segment elevation, the ECG is the primary indication for emergency reperfusion therapy. However, identification of STEMI in the setting of left bundle branch block remains challenging. Left bundle branch block is a major ECG found for STEMI diagnosis using ECG. Sgarbossa criteria and its modification. Sgarbossa, you know, is a woman, is a medical doctor, is a medical doctor, writer, Argentinian physician. It's her study is very, very important. Her study, it is a famous woman worldwide. Her study was done on 1,533 patients. Only positive patient about 33.1. No. Let us to understand about Sgarbossa criteria. Sgarbossa et al. Introduced the ECG criteria for detection of STEMI, the presence of left bundle branch block. The criteria are based on concordant SCT elevation, discordant ST elevation and anterior SCD depression in leads V1, 2, 3 with point assigned for each criterion. In several studies, the discordance of ST segment elevation criterion has been shown to be less useful than the other two criterion to mean of a high specificity. The best threshold for Sgarbossa criteria is greater than or equal to 3. A score of 3 or greater than generated from Sgarbossa criteria has been commonly used by researchers. Sgarbossa proposed requiring at least 3 points for the following criteria for diagnosis of acute myocardial infarction in the presence of left bundle branch block. Firstly, concordant ST elevation of 1 millimeter in at least one lead. This is equal 5 points. Second point, concordant ST segment depression in at least 1 millimeter in leads. V1 to 3 is equal 3 points, or third point of or third criterion, Sgarbossa criteria is excessively discordant ST segment elevation defined as a greater than or equal to 5 milli of ST segment elevation. This is the most weak point. You should know this is the most weak point in Sgarbossa criteria. What is the most common in ECG of left bundle? You can see frequently in any ECG of left bundle branch block. So it's the most weak point or criterion of Sgarbossa criteria. As you see in table, Sgarbossa A, B, C, with modified Sgarbossa criteria or Smith criterion. Smith criteria is discordant ST elevation or ST to S ratio is less than equal or less than 0.25. Modified Sgarbossa criteria superior to original Sgarbossa criterion for diagnosis of acute coronary occlusion in left bundle branch block. Hypertensive emergence is the second key in, or the third key in this case report. Hypertensive crisis, about 76% is urgence and 24% emergence, represent 3% of all patient visits, but 27% of all medical emergence. Hypertensive crisis defined the level of systolic blood pressure more than 180 and systolic blood pressure more than 120, depending on whether there are damage in vital organs or not. We can differentiate between hypertensive emergency and hypertensive urgency. Hypertensive emergency occurs in about 2% of patients with systolic hypertension. The most common symptoms are headache, dyspnea, nausea, vomiting, epistaxis, founding, and anxiety. Immediate reduction of blood pressure is required only in patients with acute end organ damage. Nitrolysis are potent vasodilators. Vasodilator reduces blood pressure, decreasing preload and cardiac output. It is acceptable choice, drug of choice in hypertension and hypertensive emergency, except in patients with acute coronary ischemia. Third point, the decision of thrombolytics in left bundle branch block. The decision of receiving thrombolytics in left bundle branch block is depending on the Sgarbossa criteria scoring. The presence of acute ischemic chest pain is share in this decision. A new or old left bundle branch block coronary stones is depending on presence of old ECG. Case presentation. Client and history, 53-year-old, married, heavy smoker, Egyptian male smoker. Patient presented to the emergency department with acute chest pain, palpitation, rapid breathing, and dizziness. Patient has a history, had recent history of psychofamilial troubles, chest pain, was anginal. There was a past history of hypertension on chest pain with on furosemide tablets daily and captopril. The patient denied history of other cardiac disease. Physical examination generally, the patient appear irritable, sweaty, anxious, and tachypneic. Vital signs: blood pressure 240 over 140, pulse rate 100, regular respiratory rate 36 per minute, temperature was normal, pulse oximeter was normal, mildly low, oxygen saturation of 92%. Otherwise of tachypnea, dyspnea, tachycardia, there is no local cardiorespiratory signs. This is the first ECG on admission in ICU. This is ECG of emergency department. As you see, there is no more data in left bundle branch block, no more, as you see. But here I noticed that T wave is not in the case, but it's not T wave alternance here. The second ECG, second tracing, starting of ST elevation in, as you see in P tracing in 1 and AVL. 1 and AVL is high lateral segments of ECG. 1 and the AVL leads is high lateral segment of ECG of the heart. 1 and AVL is the most smaller myocardial infarction in ECG, but the most painful one, this high lateral segment of ECG supplied by first diagonal branch of left anterior descending, at least not this is the most, and ECG starting after P tracing, as you see in high lateral, starting to be more elevated, and with the more elevated in 1 and the AVL leads, as you see, no change here in anterior segment, but inferior segments there are, as you see, SCT depression in lead 3 and AVL, AVF, reciprocal changes, despite it's a mild, not a more, but indicate there are a new developed acute high lateral myocardial infarction. This is known by, have a sign, is known in cardiology, is South African flag sign. Despite I am focused on this in my article. The last ECG tracing for follow-up here in the case report, ECGD, as you see, this is after within 5 hours of first ECG of admission in ICU, and within 2 hours of strep kinase IV fusion, you see normalization of SCT segment elevation in 1 and AVL, with also normalization of SCT depression or reciprocal changes in lead 3 and AVF. Troponin test was positive. this measured blood random blood sugar with mild elevation. Later echo showed anterolateral hypokinesia. No more workup. The most probable diagnosis, developing of acute SCT segment elevation of myocardial infarction, high lateral MI in the left bundle branch block post hypertensive emergency. Treatment. Patient was admitted to the ICU as a hypertensive emergency with angina and the left bundle branch block. He was initially managed with oxygen inhalation, 5 liters per minute, sublingual isonitrate tablet, sublingual captopril tablet. The initial ECG, as you see before, no need to more speak about it. The only taken score of initial Sgarbossa criteria was 2 with discordant SCT elevation in V1 to 6 or 1 to 5 to 4, more than 5 millimeter. This is insignificant, despite it helped us, but as I said before, it is a present in ECG. You can see in ECG of left bundle branch block. So don't depend on this criteria in diagnosis, but it helps you with other criteria. Serial ECG, as you see before, no need to repeat. Serial ECG tracing. Patient become symptomatic free after streptokinase infusion and controlling blood pressure. Patient was continuing on captopril, aspirin, clopidogrel, nitroglycerin, and atorvastatin until discharge in the 5th day. Discussion. Overview of middle age. Married heavy smoker Egyptian male working, presented to the emergency department with hypertensive emergency with acute severe chest pain and left bundle branch block. Primary objective for this current case was the presence of angina, sinus tachycardia, and hypertensive emergency and left bundle branch block. Secondary objective for this case was priority for management of angina, sinus tachycardia, and hypertensive crisis, left bundle branch, and how to deal with this, like this case in the ICU. Left bundle branch block is a common problem in our clinical practice, but an extremely rare to see left bundle branch block giving acute ischemia with developing of Sgarbossa criteria. The only initial criteria for Sgarbossa was discordant ST elevation more than 5 millimeters, score 2, which is very low, as I said before. This only taken score of Sgarbossa criteria indicate there is no seriousness. Appearance of concordant SCT elevation more than 1 millimeter leads with positive QRS in AVL 1 and AVL with reciprocal changes in 3 and AVF indicates CT segment elevation, high lateral myocardial infarction rather than extensive anterior stem. Return to of left bundle branch block to basic initial Sgarbossa criteria after streptokinase infusion and the controlling of blood pressure. Highlights. The current case was left bundle branch block was subsequently developed acute myocardial infarction, acute ischemia, strictly high lateral MI that was indicating for thrombolytic therapy, both hypertensive emergency and left bundle ECG left bundle branch block pattern were encompassing the seriousness consequence in this case. Serial ECG were showing a graded developing of Sgarbossa criteria of left bundle that is meeting with diagnosis of acute myocardial infarction. Upgrading of Sgarbossa criteria of left bundle branch block had happened throughout the course of hypertensive emergency, presence of left bundle angina, positive troponin, Sgarbossa criteria of 7 were indications for the presence of acute ST elevation MI, specifically high lateral MI. The only initial ECG Sgarbossa criteria with discordant ST elevation of about score 2. This is only ECG sign is a none, as you said before, insufficient indication for more serious condition. Concordant ST elevation more than 1 millimeter in one, and AVL with reciprocal ST elevation inferior leads are specific for high lateral myocardial infarction. Resolving of developing of Sgarbossa criteria left bundle to the initial condition after streptokinase infusion and controlling of blood pressure had happened. The default of this case report was failed progression of left bundle to the acute myocardial infarction. That is an indication for thrombolytic therapy or perfusion therapy. Unfortunately, there is no similar case for comparison in the past literature. I acknowledge I wish to thank the Ahmed Al-Ghubari for Engineer Ahmed Al-Ghubari for his technical support. Conclusion, the recommendation, resolving of upgrading of Sgarbossa criterion left bundle branch block and the initial status after streptokinase infusion with controlling of blood pressure will strengthen the role of streptokinase and the tight blood pressure control. The current cases considered the first reported case study where grading of Sgarbossa criteria for left bundle branch into acute high lateral ischemia during the course of hypertensive emergency. Moreover, the case report highlight important, adequate, and tight controlling for patients with hypertensive emergency with left bundle branch block. At the end, thank you very much.
Thank you so much, Doctor, for that excellent presentation.